Hello, and we're starting chapter 6 here, part A. A very, very common disorder that people deal with and that people suffer from without even realizing it, and that's hypertension. So we're going to go into sort of the mechanistic inputs that drive hypertension that we understand, and then we'll move into the drugs that we use to counter those inputs. Hypertension is actually one of the most common, if not the most common, chronic disorder that patients deal with, both in the United States and around the world, because age is actually one of the primary factors that drive hypertension. But you can see that there are all sorts of other potential factors. This is why we term hypertension multifactorial. It can be a combination of age, it can be genetic, it can be an issue of stress, it can be a problem with your heart or your kidneys, and so forth. In fact, my grandmother suffered from hypertension most of her life, from basically in her 30s, from an accident involving a homemade improvised explosive device, in other words, a firework. It had some tinfoil or something around it, and when it went off, the shrapnel embedded in her back and actually damaged her kidneys, and she suffered from hypertension most of her life. So we're going to get after some of these mechanisms. So I'm going to be talking about this a little bit, what the inputs are, for a couple of reasons. First, you need to understand the logic behind why we would go after certain druggable targets. But second, so much of this multifactorial pathogenesis actually goes outside of pharmacology. So we're trying to double dip here. I'm going to give you the pharmacology stuff, but I'm also going to give you the insight into non-pharmacologic interventions, things we can do to help improve this very vexing disorder because of so many inputs. One thing that I'd like you to become aware of, if you aren't already, is the concept. It's a medical concept known as sequelae. That is to say, the consequences of something. So if you have a heart attack, the sequelae will be risk of future heart attack, could be poor blood circulation, that sort of a thing. So it's the consequence, if you will. And this is the issue with high blood pressure, is that it's a condition that leads to all sorts of other problems, all sorts of sequelae, including risk of stroke and cerebral aneurysm, blindness, one of the leading causes of blindness next to diabetes, heart attack, hypertension will contribute to that, certainly heart failure, kidney failure, and those are just the most common ones. Okay, these are kind of the big killers, or the really debilitating disorders. But what drives hypertension as much as the multifactorial stuff that I told you about in the previous slide is lack of awareness. It sneaks up on us. It's something that happens to us without us even knowing it. It's asymptomatic. People tend to be relatively independent, don't need to go to the doctor if they don't, have to or don't want to, if you know what I mean. And even if they are aware of the hypertension, they don't perceive it as a severe enough issue to deal with. So they may be given medication or given a prescription to do something, but they don't comply. And this is where these two things are where you guys can really make a big difference. Okay, you guys can really help in this direction. Um, because of the multifactorial issues, it can be difficult to decide or implement an intervention or a therapy to treat it. Uh, and or if we don't have the exact causality exactly right, maybe the therapy that we prescribe is not going to be particularly effective. That's quite common. Going back to the days of physiology, we might recall that arterial blood pressure, and by extension all blood pressure, is determined by four physiologic phenomena. One is the heart rate and stroke volume that we call collectively cardiac output. If the heart is beating faster, if the heart is beating with more force and pumping more blood, it's going to make more blood in the circulation, in the arterial system, which will raise pressure. The next one would be called peripheral resistance, and here in the veins are in a similar thing. So these all sort of overlap. Peripheral resistance is fundamentally smooth muscle tone in the arteries that the heart has to overcome in order to circulate that blood. We call this afterload. Okay, the diameter of the arterioles. One of the things that happens in age is that the arteries don't stretch as much, and so what happens is when that heart squeezes, it sends a more forceful pressure wave. The arteries don't absorb that pressure; they just end up conducting it like a hard pipe downstream, and that ends up damaging tissue. But peripheral resistance, this is the relative diameter of the arteries and arterioles, and if they're not if they're too tight, if they're too constricted, then you'll see blood pressure rising. That's one of the reasons why vasoconstriction is part of the sympathetic side and raises blood pressure. Then we have over here, and this one's a little more, we're going to be dealing with some of the mechanisms over here in the kidney. And that's this idea of fluid volume. It's a blood volume here. We'll just more generically call that fluid volume. And what we're going to be doing is probably looking at how the kidney does its thing, and that's one of the primary pharmacologic targets is in managing fluid volume is through the kidneys. And then over here on the right, and again this sort of overlaps here. Smooth muscle tone in the veins. The veins are what we call a volume reservoir. 2/3 of your blood at any given time are in your veins. And so if that smooth muscle tone is elevated, those veins are going to constrict, those big ones that store blood, and it's going to send blood back to the heart to send out to the arteries. And so these all overlap to one degree. So it'd be just a good idea to review your physiology here, because this is the logic behind why we attack certain things pharmacologically or non-pharmacologically. So now that we've identified the primary physiologic phenomena, let's again look at the causes. I mentioned this a little bit, age and the stiffening of arteries and so forth. But then the kidney, because of the fluid volume. Arterial diseases, again, why? Because these arteries harden and they can't absorb the pressure wave from the heart, and they end up transferring it downstream. Hormones, when we get to kidney, we'll see that again. Drugs, alcohol, and the anise type licorice will all play in. Why? Because they're going to affect the liver a lot of the time. And maybe the kidney to a certain degree. And when the liver and the kidney are impaired, you start having issues with osmolarity and fluid volume. Genetic factors play into all of these things. But over here, the idiopathic, the unknown, 95%, is not entirely understood why blood pressure would go up. So again, how would these things play into those four basic phenomena? You can make these things a lot less complicated if you take it back to the basic physiology. So just look at these as an exercise and try to understand it, make the connection back to the fundamental physiology, and a lot of these seemingly intractable situations start to clear up, if ever so slightly. So taking that basic physiology, now let's look at it, those basic phenomena, in terms of organ systems. So we have right here at the 12 o'clock position, we have what they say systolic discharge alterations. That's just a fancy word for cardiac output. So anything that causes cardiac output to increase could potentially drive hypertension. We have two figures over here on the left and over here on the right. These are peripheral resistance. Peripheral resistance can either be driven by increasing the vascular tone, by causing the smooth muscle in the big arteries to constrict more, or we can um, stiffen the arteries just by age or by uh, artery disease. Okay, so we may have stiffening that's occurring here due to either, like for instance, arterial disease or just age. Okay, let me delete these real quick so we clear up the screen. On the right, we have vasoconstriction again. Again, that sort of plays into the previous one. But we also have this renin-angiotensin-aldosterone system. That's a very, very important fluid volume management mechanism that we're going to look at pharmacologically because it's a major target. So, but all of these things are fundamentally influenced by something we've already talked about, and that is the sympathetic autonomic nervous system. So that's where stress can play a role, because it will control all of these things in one shape or another. So you see how it's all connected in some ways? These things could occur on their own, like maybe you have a malformation in the heart, or it could be a malformation in the blood vessels, or it could be something wrong with the kidney, and those could drive it, or it could just be something from the sympathetic nervous system that's causing them to be hyperactive. Another way to describe causality in hypertension is what we call secondary. So in the previous slide, we were looking at primary hypertension, also known as essential hypertension. If you've ever heard that phrase, essential means it's driven by one of those primary causes. On the other hand, we can have what are called secondary causes of hypertension. They're not that distant, but nevertheless, they are important to understand. So for instance, if you have Cushing's disorder, that's hypercortisolism, that can lead to hypertension. We have hyperaldosteronism, also called Conn syndrome. Aortic coarctation, that just means a malformation, a misrouting of the aorta. Pheochromocytoma, that's a type of tumor that secretes hormones that can actually drive a lot of these first three categories. And then the renal arteries, if they have stenosis for any reason, that is narrowing, either because of the formation of them or from our arterial disease. So we use the mnemonic CHAPS in order to remember these causes of what we call secondary hypertension as opposed to essential hypertension. Physicians have known for a long time the dangers of hypertension and have tried very hard for the last 70 years or more to control hypertension. Starting with diuretics in the 50s and 60s. As the molecular understanding improved, we started to see beta blockers and what we call sympathetolytics. If we have sympathetomimetics, those are enhancing or initiating the sympathetic system, but if you have a sympathetolytic, you're blocking or reducing sympathetic stimulation. And as we've gotten further and further along, we are getting more and more specifically molecular. And that's one of the things why, as an undergraduate instructor, I keep trying to push students, even if they're not interested particularly in molecular biology, because that's where all the therapies are going. And so getting that early start helps make learning some of the newer drugs a little bit, just ever so slightly easier. A couple of concepts involving cardiac output here that we need to start talking about. And again, we'll see this when we get to cardioactive drugs because it's all related. It's this concept of preload and afterload. Let's start with afterload first, only because I think it's a little easier to wrap your brain around. If you know, six another half dozen, that sort of thing. So afterload is how much work the heart has to overcome in order to get that blood out of the, usually the left ventricle is the big one. It's very rarely that you'd have a big afterload issue in the right, unless you had some sort of embolism or something. In any case, it's how hard, how much force the heart has to exert in order to get that blood downstream. And so we call that afterload. It's the resistance that the ventricle must overcome. And this is often elevated in hypertension because you have vasoconstriction, maybe elevated stress, artery disease, and so forth. So more work for the heart to do to overcome what's known as afterload. Preload, on the other hand, the issue with preload is that whatever blood comes in, the heart's going to want to squeeze it out. So if you have more volume coming in, it's going to stretch the heart a little bit more. It's going to invoke something called the Frank-Starling law that we talked about in physiology, and it's generating more work for the heart as well. Okay, so when you send more blood back, and this can be due to venous constriction. Okay, so when we have that constriction of the veins, that volume that they're storing gets sent back to the heart and becomes preload and makes the heart work harder, sends more cardiac output, and that in turn causes elevated blood pressure. So we do see vasoconstriction mediated afterload, but we can also see vasoconstriction mediated preload. Now that we have a little understanding about how hypertension can be caused, let's start the conversation about how hypertension can be prevented and or managed if it exists. When it comes to drugs, we actually have a sort of simple mnemonic to remind us of what's possible. We have A for ACE inhibitors, B for beta blockers, drugs that end in OLOL or LOL. We have C, calcium antagonists. That's going to address smooth muscle as well as cardiac output. And then I'm going to add a D in here for diuretics, getting after fluid volume. So we have a list of drugs here, and we're going to go after some of these. Some of these we'll probably cover in this chapter. Some may show up in other chapters. I'm not going to get to it right away. We're going to continue to talk about management of hypertension in other ways above and beyond just the pharmaceutical side of it. And yes, this is a pharmacology course, but we would be remiss if we didn't include at least some basic non-pharmacologic management. Think of it this way. By understanding the potential possibilities of side effects and toxicity and long-term compliance with drug therapy, why not use that knowledge to reinforce the idea that, hey, we can do this non-pharmacologically almost as effectively? First thing, relatively straightforward, is try to reduce salt, that is to say sodium. For example, you can actually substitute magnesium chloride, which is the primary component of sea salt, for regular table salt, and it tastes just as good, and in fact I think it tastes better. Reducing fat, I would also, in this vein, fat has had a bad rap for a long time. At the expense of understanding that it's a combination of fat and simple carbohydrates. That is to say, high fructose, high sucrose in combination with high fat. We're rapidly finding out that excess carbs are as much a problem as excess fat. So again, fat in moderation and certainly carbs in moderation, because the two together are probably more of the problem than one or the other. That leads us to maybe just reducing calories. If we're going to reduce carbs and fat, we're reducing calories. Try to keep that BMI in a range within reason, because BMI is just a number. It's a good indicator, but it's not always the entire story. What you're going to try to do is get them to be more fit, depending on their body type and so forth, and more active. Yeah. Regular exercise, 30 minutes a day, and it doesn't have to be heavy-duty exercise. It turns out just good old walking, good old going up and down stairs is a great way to go, and you guys are going to know that in spades. Quitting smoking. Say no more. Why? Because it contributes to endothelial disorders that lead to artery disease, among other things. Alcohol consumption, again, moderation, not more than 2 drinks a day for men. Again, it depends on body mass more than if it's male or female. 1 drink a day for women. And managing stress, because why? Sympathetic input. There's a great system out there. We call it the DASH diet, and you'll probably be learning about this quite a bit. Low in saturated fat, low in cholesterol, emphasizes fruit, vegetables, less dairy foods, and more whole grains and so forth. Good stuff. I also talk about eating across the rainbow. You try to eat the rainbow. So you try to diversify your food intake by diversifying the colors in your food. But again, you guys are going to get more of this, but I want you to keep thinking in that direction, that the pharmacology is a part of the larger holistic picture, and that you can use that knowledge to reinforce the non-pharmacologic stuff. But let's now get back to the pharmacological side. When it comes to the internal mechanisms of regulating blood pressure, we have a fast response, which is mediated by the sympathetic and parasympathetic systems. These are ones that will regulate heartbeat as well as constriction of vessels, either the arteries or the veins. So this is a fast response, and it's good for adjusting from moment to moment. It has limited total efficacy, but it is good in the short term. And then we have a longer term, slower response, which involves renin and angiotensin and so forth. And we're going to talk about that as well. So what we're going to be doing over the next few slides is sort of putting these together so that you can see the pharmacologic approach. So here's an example of that fast pathway. You have what are called baroreceptors that are found in the aorta. There's one right here in the carotid. And what they do is they can sense mean arterial pressure, and they will send signals to this controlling center in the brainstem that will then dial up or dial down, respectively, the heart. And it may also cause vasoconstriction indirectly through the adrenal medulla. So that's what we have here. So the reflexes that control those fast responses are both sympathetic and parasympathetic. And they are direct when it comes to mediating the heart, indirect when it comes to things like vasoconstriction. But these are all potential targets for therapy. Above and beyond the sympathetic and parasympathetic system, there are other mechanisms at play which are a bit slower than those moment-to-moment ones, but nevertheless are powerful vasoconstrictors and vasodilators. And so the book talks about this a little bit on page 68. So I wanted to just give you a little overview of what we're looking at here. And there's sort of three big molecules that are particularly attractive from a therapeutic standpoint. The first one is nitric oxide. It's actually a gas. We'll talk about nitric oxide here in a second. We also have a molecule called endothelin that's a little more on the molecular side. It's a vasoconstrictor. And then the third one is called thromboxane. And there's the A2 form, not too worried about that. But the point here is that we actually have agents that can take advantage of two of these three pathways right now. One are these molecules called nitric oxide donors, and for instance, a nitroglycerin tablet. If you've ever heard the commercials for don't take nitrates for chest pain if you're taking Viagra or something, well, they're talking about nitric oxide donors. Aspirin is a very familiar pain reliever, and that's because it will inhibit the enzymes that create pain signaling molecules, among other things. It can also block coagulation and modulate and block vasoconstriction, I should say, by blocking the creation of this molecule called thromboxane. So those are two drugs that are already in the arsenal that can be used as adjuncts, as additives on drug therapy. The longer-term control mechanism is a pathway known as the renin angiotensin aldosterone pathway. It's a cascade of signals that begin in the liver, is initiated by the kidneys, perpetuated by the lungs, that send a signal to the adrenal cortex, the outer layer. The catecholamines are made in the medulla, the middle, But the hormone that's the effector hormone in this case is called aldosterone, and that in turn signals the kidney to retain more sodium and more water and increase blood pressure. But let me go through this slowly, and I'm going to mark this up a little bit. So let's start over here with the liver. The liver is a very important manufacturer of soluble proteins and precursors for the bloodstream. And one of those soluble precursors is this peptide precursor called angiotensinogen. When you hear that inogen, think precursor. It is a precursor of angiotensin, so it's an angiotensin precursor. So the liver is going to make those. It makes a lot of different proteins for the bloodstream, albumins, and all that fun stuff. And so you've got angiotensinogen circulating through the bloodstream. Well, here's the kidney, and the kidney is actually a sensory organ. So if the kidney senses decreased perfusion to the kidney, decreased blood pressure, and other signals, it will start manufacturing a protein called renin. Okay, this renin protein is actually an enzyme that converts angiotensinogen into angiotensin 1. Angiotensin 1, the first form of angiotensin. Okay? So when renin is secreted, it starts converting angiotensinogen to angiotensin 1. And I say 1 because we have a couple of forms of it. Now, angiotensin 1 has been made, and as it circulates through the blood, it encounters the lungs. And when it gets to the lungs have an enzyme that they secrete on the surface of the blood vessels inside the lung. It is known as angiotensin converting enzyme. It is an enzyme that converts 1 to 2. It's a cleavage enzyme. Here's the fun part. As if it was fun, right? This enzyme happens to be one of the primary targets for COVID-19. That's why COVID-19 is creating, in part, this sort of acute respiratory distress syndrome. Okay? The virus binds that ACE enzyme. We abbreviate it ACE. Let's see if I can write it here. Okay. That's what we mean by ACE inhibitors, by the way. I'm getting a little too ahead of myself. In any case, that angiotensin converting enzyme is converting angiotensin 1 to angiotensin 2. Now we've got angiotensin 2, a slightly shorter peptide, Angiotensin 2 is circulating through the bloodstream, and it can act as a vasoconstrictor. Okay? It can act directly on the vasoconstrictor. But the more powerful thing that it can do is that when it goes to the adrenal cortex through its normal circulation through the blood, it will cause the adrenal cortex to now secrete this hormone, which is now a sort of a steroid hormone called aldosterone. It's a lipid hormone. It's a steroid type hormone, aldosterone. And then aldosterone circles back to the kidney through the bloodstream and tells it to resorb sodium, and then water comes along for the ride. It actually triggers the transport of sodium transporters to the surface of the tubule, starts transporting sodium, and then water comes along via osmotic pressure. Okay. So more aldosterone means more sodium retained, more water retained means more fluid, which means more blood pressure. Okay. It's an intimidating mechanism at first, but if you take it one step at a time, it's not as intimidating as it might seem. And what's great about this pathway is that there are potential targets. We could target ACE, and we've been targeting ACE for a long time. We can target the secretion of aldosterone or the aldosterone receptor or the arterial receptors for angiotensin. There are any number of targets in this. And ACE inhibitors have been leading the charge on this, but more recently we're starting to see angiotensin receptor blockers and aldosterone receptor blockers coming in. But that angiotensin converting enzyme is really, really interesting from a therapeutic standpoint. Tends to be very, relatively effective because you're preventing the creation of angiotensin 2. Angiotensin 1 doesn't seem to do anything. Angiotensinogen doesn't seem to do much of anything either. So by blocking that converting enzyme, you've kind of blocked a keystone step that prevents the rest of this from happening. But work on it one step at a time, because you will see ACE inhibitors in your career and other antihypertensives. This is just the same figure as before. It's just showing it to you in a slightly different way. So we have our liver making angiotensinogen. When kidney senses low perfusion, low pressure, it releases renin, and that triggers the conversion of angiotensinogen to angiotensin 1. Angiotensin 1, when it goes to the lungs, will encounter ACE, and ACE will convert it to angiotensin 2, which can act in a number of ways. It can work on sympathetic activity. It will certainly go to the kidney and trigger aldosterone. There may be a direct pathway as well. It will modulate vasoconstriction, maybe do some antidiuretic. There's lots of possibilities. You don't have to worry about every single detail. Let's work on just the core pathway. That is to say, angiotensinogen converted to angiotensin 1. That's where ACE is. ACE will convert 1 to 2. 2 will go to the kidney, so cause the kidney to release aldosterone, and that means we retain more water. But having an awareness of what else it can do will be helpful in terms of potential side effects, why they might do one thing or another down the line. But get to know this, because this one is one of the more common therapeutic pathways that we target, especially for hypertension. Oh, by the way, this is the angiotensin 2 molecule. It's a peptide. So these are renin's actually a protease. ACE is actually a protease. That's why it's so wild that the virus targets a protease in order to get inside the lung endothelial cells. So we have the renin-angiotensin-aldosterone pathway, which is primarily involved in regulating the amount of sodium transport through this area, sodium, and then that leads to water reuptake, particularly in the distal tubule and the collecting duct. So, but we also have another mechanism that works a little bit upstream of it, and it's called tubuloglomerular feedback. They don't mention it in the book, so I'm not going to delve into that too much. But nevertheless, what's going on is it's going to regulate the filtration rate here in the glomerulus, GFR, which is a major diagnostic number for folks that are at risk of kidney failure and or hypertension. So what's happening, and I've got it circled here, is that there are special cells here in 4. They're called macula densa cells. They can sense the amount of flow coming through this tubule. So as the filtrate flows through here, they go by that number 4 there, and the cells will sense that, and they can actually do qualitative and quantitative sensing there. What they will send when they sense increased flow is signals that will constrict and dilate those arterioles. The dilation and constriction of those arterioles changes the hydrostatic pressure here on the glomerulus, and thus changes the filtration rate. If we have too much filtration rate, what will happen is we'll dial down the smooth muscle here in 5, we'll clamp it down and lower the pressure so that the filtration rate slows, and vice versa. If we have too little flow, we will open up here the smooth muscle at 5, causing more filtration rate. These are mediated by a set of molecules called prostaglandins, which you might have heard about in terms of pain signaling. Prostaglandins are also used to modulate the diameter of the vessels here at 5 and then hiding back here behind 4. There's an afferent and efferent arteriole, and they work in opposite directions. So if you want to do a little motor memory here, put two fists in front of you between you and the screen. One hand is going to open, so you're going to have an open hand, and the other one's going to be in a closed fist. Think of that in terms of vasoconstriction and vasodilation. So one hand is open and one hand's closed. Now switch them. Now the other hand is open and the first hand is closed. So right now my left hand is open, my right hand is closed. They don't close all the way, but they work in the opposite direction. So when these prostaglandins are secreted from the macula densa, they modulate they modulate vasodilation in the afferent arteriole while modulating vasoconstriction in the efferent arteriole. And that in turn affects pressure in the glomerulus and flow rate. Prostaglandins are enzymatically created from this precursor called arachidonic acid. And I can ask you to recognize that. It's a lipid, very common, found in the plasma membrane. What happens is it gets cleaved off and becomes this molecule that can then be converted into this cyclic molecule. It's got a full circle here of carbon. This is the signal for vasoconstriction and vasodilation. Let me show you where this goes. Well, if we have prostaglandins here and we're on, say, NSAID therapy, NSAIDs are blocking cyclooxygenase enzymes. So if you're taking too high a dose of NSAIDs or you're taking chronic administration of NSAIDs, you can suffer renal toxicity. So we will have issues here for a number of reasons. For instance, sympathetic, if we're over-sympathetically stimulated, what happens is mean arterial pressure rises and we get an increased filtration rate, maybe beyond the point that this tubule can compensate. We can also either have ischemia, either because of artery disease or because of nephrotoxicity from too much cyclooxygenase inhibition. That's the primary mechanism for NSAID-mediated nephrotoxicity. Trauma, certainly. We also may have too much antidiuretic hormone. There's a syndrome called SIADH, the syndrome of inappropriate antidiuretic hormone. If we're pulling in too much sodium and water, our pressure will rise, our filtration will rise, and then we're going to get all kind of mucked up a little bit. And so these are kind of four major clinical aspects of this mechanism. If you are confused, we can draw this out or we can work on this in synchronous session. But the bottom line is that this is another compensatory mechanism dealing with hypertension. Here it is shown another way. I've got a more complex figure up here, but here's a nice little stylized figure. We have the afferent arteriole coming in here, and I'll use my little handy-dandy highlighter. So the blood's coming in like this, going through the glomerulus where some of that material is being filtered, and eventually most of it will be recaptured on the downside later on. If we have an issue with prostaglandin inhibition because of cyclooxygenase, we're going to clamp down on that inflowing arteriole, and that can lead to not only reduced glomerular filtration rate, but it can be overt nephrotoxicity, and that's why we have this NSAIDs and COX-2 inhibitors right here. So hang on to that, because we're going to see this when we talk about other aspects of kidney function. That's one of the main ADRs that we see in one of the most commonly used over-the-counter drugs is reduced urine production, which is indicating that there's the chance that they could do irreparable kidney damage because of that drug. By the way, here's angiotensin 2 over here. It modulates the efferent arteriole a little bit. That's part of the larger mechanism of the renin-angiotensin-aldosterone pathway. Segueing from that tubuloglomerular feedback mechanism that I just showed you, you know how I said SI-ADH, the syndrome of inappropriate antidiuretic hormone? That's actually one of the causes of the secondary hypertension. It's actually an inappropriate signaling of that secondary hypertension. So that's why this table is so comprehensive, because there is a ton of ways that we can induce antidiuretic hormone accidentally. That can be stress, it can be sleep apnea, alcohol abuse, you name it. Almost anything can induce SIADH. Drugs, NSAIDs can drive this. We've talked about that before. Lots of possibilities for secondary hypertension due to the fact that it's affecting ADH, it's affecting blood flow to the glomerulus. So we're just hitting the 40-minute mark, and I just wanted you to know that there's a section starting on page 69 of your book talking about the classification of blood pressure. I am going to go ahead and pass on this with the idea that you're probably going to see this later on. I'm hopeful that you will. If not, you'll pick it up eventually. It's not that difficult, but it's really just numbers that you look up in a table. So we're going to go ahead and skip that for now. And that does it for part A. We're going to revisit some of these things when we come back in part B. We're going to get more into diuretics. I don't have the D over here, the D for diuretics, but we're going to see how these things do their magic in part B of chapter 6. Thank you.